This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Gregg from Mayo Clinic in Jacksonville, Florida. Today I have the pleasure of interviewing Vijay Ramanan, a friend, colleague, behavioral neurologist, and director of Mayo Clinic's Alzheimer's disease treatment clinic in Rochester, Minnesota. Vijay is also an author on the paper published in Neurology titled Eligibility for Anti-Amyloid Treatment in a Population-Based Study of Cognitive Aging. Vijay, thanks for joining me today.
Thanks very much, Gregg, for having me. Excited to chat.
Our regular listeners know that emerging monoclonal antibody therapies for treating patients with Alzheimer's disease are a pretty newsworthy topic. So we've been covering this topic since June of 2021, when the FDA made the rather surprising decision to grant aducanumab accelerated approval. Aducanumab was the first-in-class infusion medication shown to reduce cerebral amyloid burden in patients with early symptomatic Alzheimer's disease. But as we've discussed on this podcast before, the clinical trials that led to that accelerated approval left many questions unanswered, particularly questions pertaining to the safety and efficacy of this drug, while raising many other relevant concerns. Ultimately, Vijay, I think you'd agree with this. Those concerns generated lots of discussion amongst researchers, clinicians, patients, and payers, but culminated in pretty poor uptake of the drug in clinical practice. Flash forward to today, it's 2023. We now have this drug, lecanemab, the next-in-line monoclonal antibody supported by data from a well-designed and conducted clinical trial that clearly showed amyloid clearance from the brains of patients, again, with early symptomatic Alzheimer's disease, and a modest, yet statistically significant slowing in the rate of decline in patients receiving drug versus those receiving placebo. These results led to full approval of lecanemab earlier this year, with the medication now available for use in patients with mild cognitive impairment or mild dementia stages of Alzheimer's disease. It's this environment that your team's manuscript arrives in, testing the waters, I might say, and raising some key and very relevant questions about the potential generalizability of the criteria we use to select patients for the clinical trial for lecanemab and other relevant clinical trials. How generalizable are they to our patients in our clinics who we plan to use these medications on? Hopefully I summarized the lay of the field well to set you up, Vijay, but why did you and your team think it was important to write this paper now?
There's intense interest amongst all of us, clinicians, patients, loved ones alike, about new treatment options for what can be a really devastating disease. We think we all want as many options as we can get our hands on. And so having the news about lecanemab is a positive step forward for patients and for the field. We can also balance that against the nuances and complexities about these drugs. We know that drugs like lecanemab are not cures for the disease. Their aim is to modestly slow progression by acting on one element of the disease process. We know that these drugs are complex. They have their side effects, principally brain swelling and bleeding, referred to as ARIA, potentially other complications too. And as you weigh those things with the lifestyle changes of frequent infusions, traveling to centers for medication, MRI scans, other follow-up, all of this is potentially quite intensive for patients. And so even just from that high-level background, as a clinician, my instinct would be that these drugs are options, but will not be the right option for every patient with Alzheimer's disease. And as our field and related fields are tussling with these issues, our research team actually thought it was worth taking a step back. We know that clinical trials are not the same as clinical practice. They have different designs, different aims, but particularly for new and/or complex treatments, these fit into that category. Clinical trials do provide an initial evidence base for gauging efficacy and safety. In other words, the population that's studied in a trial and the conditions under which they were studied provide some initial guideposts for translation to the real world. And so if we know from a starting point that lecanemab is approved for use in individuals with early symptomatic biomarker positive Alzheimer's disease. And we know that enrollment in lecanemab's clinical trial required meeting numerous criteria. There's a natural question that I think comes to mind, and that is, what if you applied those trial conditions, those criteria for inclusion and exclusion, to a population-based sample of individuals who fit that profile, who have early symptomatic biomarker positive AD? And the idea being doing so really ought to give the field and our patients some information on how generalizable that trial data may be to a broader population. And so that's why I think now is exactly the time when clinicians and patients, in their counseling and pursuit of shared decision making around these new options, would really benefit from this data. And so this effort was spearheaded by a colleague of ours, John Graf Radford, as well as Maria Vasilaki and first author Riona Pittick, and leveraging a data set that we felt was almost perfectly able to answer that question.
I agree. I think you're talking about the relevance to our patients, the relevance to clinicians, all those of us who are going to be prescribing this medication. And let's not forget the relevance to payers, anyone that's paying attention to the news, certainly anyone that's paying into insurance plans, including Medicare supplements, is aware that there's concern that this medication could roll out to the millions at costs in the billions or even higher. And so knowing how many patients in our clinical practice might be eligible is, I agree, a very relevant question for everyone involved. With that in mind, talk us through your cohort and the major findings of this paper.
This paper analyzed data from the Mayo Clinic Study of Aging, or MCSA. This is a longitudinal cohort study where participants are actually sampled from the population of Olmsted County, Minnesota. So this is a population-based sample. And those participants are seen for enrollment and at approximately every 15-month intervals thereafter, where they're getting quite comprehensive assessments, a visit with a neurologist, neuroimaging and fluid biomarker studies, genetic testing, detailed cognitive testing, and there's also regular abstraction of the medical records to identify comorbid conditions. And so having all of that multimodal data is a great foundation to try to answer the question that was on the mind of this study. Here, if we consider the more than 5,000 older adults who are part of the MCSA, just about 2,000 of those had amyloid PET scans, and that's important in thinking about this population of biomarker positive mild stage Alzheimer's disease. Among those patients, just under 900 were amyloid PET positive, so they had evidence of abnormal accumulation of amyloid plaque burden in the brain. And out of that group, 237 were classified clinically as having mild cognitive impairment or mild dementia. And so that group, that 237, were really the focus of this study. They had MCI or mild dementia and an abnormal amyloid PET. And for those individuals, we applied the clinical trial criteria for Clarity AD. And as a secondary portion of the work, also looked at the criteria for aducanumab's phase 3 clinical trials. So this included a variety of data points: cognitive test performance, functional assessment ratings, as well as active and prior neurologic and systemic medical conditions. And after we applied those criteria, we found that it was actually a small fraction, less than 10%, of those patients with mild symptomatic biomarker positive Alzheimer's disease who would have qualified for the lecanemab trial. And if you broadened the process and say didn't include some of the specific cognitive criteria that maybe are part of formal neuropsychological assessment, it's not like the fraction of patients who would qualify dramatically increased. They slightly increased. And we found a similar character of findings when applying aducanumab's clinical criteria to this population. And if anything, a smaller proportion of patients were eligible. So the key take home being, looking at a population-based sample of older adults from a clinical and biomarker standpoint, fitting the profile of patients who might be reasonable to consider lecanemab for. And it was actually all of the other criteria in those clinical trials that would have excluded more than 90% of them.
So thinking about the clinical trials, I think we all appreciate that it's hard to get into a clinical trial. We really are selecting, hopefully, those that are maybe most likely to benefit and least likely to be harmed. What are the key trial inclusion and exclusion criteria that led to that 90% reduction in potentially eligible patients to receive this therapy in the clinic?
For lecanemab, it turned out that more than half of those initial 237 patients would have been excluded based on cognitive or functional measures required for inclusion in the trial. So these included the CDR score, which is a standardized rating scale of cognition and function, very widely used in the field of Alzheimer's disease in many research studies, as well as a score of memory performance, which is typically part of neuropsychological test batteries, in some cases a mini mental state exam score. Medical comorbidities were really the other big factor, with some of the most frequent exclusions coming from cardiopulmonary conditions, things like coronary artery disease or significant heart rhythm abnormalities or a history of cancer. The two other big categories, one, coexistent neurologic conditions were also quite common exclusion factors. So these would, for example, relate to things like seizure disorders, Parkinsonism, or prior intracranial injuries or major head traumas. The other major reason actually was MRI exclusion factors. So because of the risk of ARIA with these drugs, and particularly with that risk being magnified in individuals having a higher burden of amyloid angiopathy, which is often coexistent with symptomatic Alzheimer's disease, there are some requirements both in the FDA label for lecanemab as well as in most concept of appropriate use that, for example, there be 4 or fewer microhemorrhages on an MRI prior to treatment, or that there not be any sign of superficial siderosis or very large cortical infarcts. Turned out in this population-based sample, nearly 40% of individuals with that early stage biomarker positive AD had MRI exclusions at the time of their PET scans. These were some of the most common reasons why that 90% plus would not have qualified for the clinical trials.
I think there's an important point to be made here as well, that you're talking about the Mayo Clinic study of aging. This is an engaged population-based research study. You've got people coming in multiple times for imaging. Is it fair to say that these patients who form the research population you're looking at may be even healthier than our typical clinic population? So maybe not as healthy as the clinical trial population, but perhaps still healthier than the patient that I'm going to see later on today. Does that seem a potential concern?
It does. And I have to say, Greg, thinking more broadly, that matches very well to what I see as a day-to-day clinician in cognitive neurology. In many ways, this profile from a population-based research study sort of matches what we see in the real-world clinic, but individuals who tend to enroll in studies like this, if anything, might be medically healthier than their real-world counterparts. And so I think this is important information for all of us as clinicians and for our patients to understand. We can start from a foundation that clinical trials and clinical practice are not exactly the same. They're not meant to be exactly the same. Treatments cannot simply exist in the real world as pure 100% extensions of what happens in clinical trials, but accepting the limitations of what we know now from clinical trials, I think will be quite critical as we're thinking about what is a new stage in our management of Alzheimer's disease.
You commented on the potential exclusions simply based on MRIs. That emphasizes the importance of working with our neuroradiologists to develop key high throughput protocols to identify these small, often small microhemorrhages that could present a serious safety risk for patients coming onto this drug. And then there's the whole set of patients that won't get in the scanner that have many different indications for MRIs. And we need to be mindful that they weren't in the clinical trial. They're not included in your Mayo Clinic study of aging data set, and they really shouldn't be included in the clinic-based population receiving these drugs. So you talked a little bit about clinical practice and how we're going to translate these findings. Let's talk for a moment about the implications of your findings for the real-world practice. Are you suggesting that these drugs are likely to be offered to less than 10% of patients with Alzheimer's disease overall? Or is your take that a lot of patients who receive these drugs may not do as well as what we saw in the clinical trials, or may experience substantial safety risks, potential adverse events?
This paper, to be clear, is not making recommendations on which patients to treat or not treat with lecanemab. That's a separate issue beyond the scope of this particular study. And I'll refer interested listeners. There are manuscripts from expert author panels on appropriate use recommendations for lecanemab and aducanumab. There are also manuscripts in the Green Journal which focus on implementation of these therapies in clinical practice. But having said that, there is certainly a general general consensus in the field, particularly among subspecialists who are seeing these patients in great focus, that for such new and complex medications, those clinical trials do give us some initial guideposts. And it's interesting that most of the concepts about appropriate use of agents like lecanemab in the real world are actually fairly closely aligned to the conditions of the clinical trials. And I think that is simply reflecting that is the population where we have that initial data on efficacy and safety. We will learn more as these drugs are utilized in the real world. One could certainly imagine there could be use of lecanemab, for example, in patients who may not have qualified for the clinical trial based on some measure of inclusion or exclusion, but where use is adhering to the FDA drug label. So there are not overt contraindications to use, but there are uncertainties, at least to a degree, as to safety and efficacy. And so here I think is where an emphasis on shared decision making will really be critical. So relaying to patients that the question on their mind, the right question, does it work, doesn't have a simple and straightforward answer. There is nuance. And all of us collectively accepting that nuance and accepting that there is complexity in those discussions, that there are going to be some cases for which we don't have a firm, hard set prognostication prediction for our patients, but that where use could still be very appropriate. And so this paper, I think, is helpful for patients to have an initial expectation and an understanding that the data we have from that clinical trial population, yes, represents a fraction of the patients that will actually potentially even be receiving this drug. And I think with additional real world experience, we are going to learn more. So concepts of appropriate use in clinical practice as of today, I am quite confident will evolve over the coming 6, 12, and 18 months as we gain more experience and as we also get more data on other drugs in class, which are in late phases of clinical trial or review.
Really, when we're thinking about how we're going to roll these drugs out, I think it seems like what you're suggesting is we've got our clinical trial guideposts. We've got this unique, perhaps very small percentage of overall patients that are enrolled in the clinical trials. And based on findings in that highly selected group, we have a reasonably thin benefit towards efficacy over safety concern. And then that's fueled a lot of ongoing discussions. And it's probably reasonable and practical if we're seeing patients that fall outside of that clinical trial population, as you said, we're going to need to engage them in shared decision making to recognize and accept ourselves and help them accept that their perception of efficacy, their likelihood to benefit, may be less than patients in the clinical trials, or I suppose maybe even potentially greater. And same thing goes for safety. And so setting up barriers, guideposts so that we know how to monitor those patients, catch the potential adverse events early and intervene as necessary. Thinking about adverse events, thinking about safety concerns, and thinking about efficacy, and thinking about our population. You've got your study population here. A lot of them were excluded. Some of them in your clinic, you might have made the decision to include. How are you interpreting what would be sort of relative contraindications and absolute contraindications? What do our listeners who may be thinking about starting to use this medication in their patients need to know about there?
The answer is not going to be one size fits all. And there are at least two important planks, one of which you led off with just a moment ago, that anyone clinically considering use of these medications, they are more complex. They are different in so many ways compared to our historical options for managing Alzheimer's disease. And so there really is an imminent need as a field and at an individual clinician and practice level to make sure that that systematic infrastructure for taking care of patients, both to get appropriate patients selected for treatment and to have the mechanisms, the personnel, the testing needed to follow patients, especially because not only are these treated patients going to need fairly regular scheduled safety monitoring, MRI scans and other things, there's the potential for unscheduled or unpredictable events. And so upfront, making sure that that infrastructure and those processes are in place are really critical. It is not simply a matter of having a new option that's FDA approved and having the ability to prescribe it. It's much more involved than that. I think the second piece of this is I would hope studies like this and others in category provide our clinicians with a foundation to have those 5 or 10-minute discussions with our patients. I think you and I in our clinical practice have been having these for many months, and especially over the last 1 to 2 years as developments around these drugs have been progressing. And I find that there is just no substitute for taking that time and engaging with our patients on their goals of treatment, their preferences and their values, and then bringing them back to the context of what we know and don't know about these drugs. And so I find it is actually very helpful in my clinical practice to mention that our best estimates are that less than 10% of patients in the general population with early stage Alzheimer's disease will likely be very strong candidates for these drugs. And then moving from there, there's a second stage. Some patients are going to have absolute reasons why they cannot be prescribed these medications. You hinted at several of them earlier. MRI contraindications, the inability to get an MRI, histories of things that would very clearly predispose to severe potential side effects, things like brain bleeds in the past, use of anticoagulant medications. And so those represent a part of the discussion. And if those things are there, it's important for us as clinicians to be upfront with our patients and not let that end the discussion, because Alzheimer's disease management really is best served when it is comprehensive. There are many different strategies. We accept that those strategies right now are not cures, but many different strategies that I think are critical to individualize to the person in front of us. And then the second thing is where those cases are very complex, where there are no absolute contraindications, no clearly overt safety concerns, but where there are some hints in the picture or some uncertainties, being upfront with our patients about those things as well, and then engaging them to weigh on an individualized basis that potential benefit of slowing of disease progression. Does that sit well with them? Is that well balanced against the potential for risks, the lifestyle modifications, the cost, all of the other things that fit in here? And I hope where this paper adds value is in giving a high-level overview, both to clinicians and patients, that though we have these new options, they really may not be the right option for every patient with Alzheimer's disease, and that does not need to end the conversation. There is more to come in this field. There are other options that are not anti-amyloid monoclonal antibody therapies, and so it's a facet in our discussions and our management. It's an exciting time and a good step forward for patients, but there's much more to come.
I love that response, Vijay. Keeping the patient at the center, recognizing that this is one step in the right direction. There are more steps to come. Thank you for translating this from the clinical trial population to a population-based cohort study. I know we can all look forward to some further great work from the team and from many others who are already treating patients with these medications as we look to understand how does this drug respond in a true clinic population. Who is it that should absolutely be receiving it? Who absolutely should not? And what are all the considerations to weigh in between? Thanks for taking the time to discuss this important paper. I've been speaking with Vijay Ramanan, one of the authors on the paper titled Eligibility for Anti-Amyloid Treatment in a Population-Based Study of Cognitive Aging, which you can and should read in Neurology. Thanks, Vijay.
Thanks so much, Gregg.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.